Okay. Oops. Okay, so back again, tomography. So I'm just going to say it again for the recording. So panoramic imaging is basically tomography, and this technology is imaging and is an imaging process that's obtaining a radiographic image slice by blurring anything in front and behind it. And the way it works, if you think about if this is my pencil right here, imagine that your X-ray source is on one side and that your film or your sensor on the other side, right? And now these things are going to be rotating. I'm blurred, so that's weird. It's going to look weird. I have to put next to my face. So it's going to rotate around, okay, with each one on the other side of this. The center of rotation is where my area of interest is the area that I'm trying to image. And that's how we get blurring in front and in the back. We're going to get into details of this, but just so that you guys understand that statement, that the X-ray source and the film move simultaneously in a way that the structures in the image are plain and clear. This plane, there's a plane in the center that is at the point of the center of rotation. That is going to be the clear area that we're going to see. And we're going to take a look at this using videos, so it's easy to understand. But the easiest way to understand it is two things hanging on to this. And then as we turn it around, anything in the middle is going to be clear. Anything in the front and in the back are not going to be clear. By the way, guys, if you have any questions, stop me and just open your mic and talk as if we were in class, please. Okay. So tomography. Let's take a look at this.
Conventional radiography captures all the structures in the path of the X-ray beam on a single image. Shadows of any structures that lie in the same plane will be superimposed on each other in the resultant radiograph. Interpretation may be hindered when an area of interest is obscured by surrounding anatomy. For example, this posterior-anterior skull radiograph is taken with the X-ray beam directed through the back of the head towards the receptor, which is in front of the patient's face. If assessment of the anterior teeth was desired, it would be difficult due to the superimposition of the image of the cervical spine. Tomography is a radiographic technique that allows the visualization of a structure free from its surrounding anatomy. Panoramic tomography is a specialized application of tomography which is used in dental radiography to image the teeth and jaws. The word tomography comes from two Greek words, tomos and graph. Tomos means to cut or section, and graph means to write. Tomography obtains a radiographic image of a slice of anatomy by selective blurring. Shown here is the X-ray receptor, the X-ray source, and an object to be imaged. The yellow line represents the path of the X-ray beam from the source to the receptor. The object contains three letters, A, B, and C. These letters sit in different parts of the object, with the letter A positioned closest to the receptor and C farthest from it. The letter B lies between letters A and C. If the letter B is the object of interest, and a conventional radiograph is taken to attempt to image it, shadows of letters A and C will be superimposed on the resultant image, obtains a radiographic image. Shadows of letters A and C will be superimposed on the resultant image and obscure the letter B.
Okay, guys, I'm so sorry. I'm trying to figure this stupid annotation button is not allowing me to pause the video. Okay. Yeesh. 1 second, because I want to pause the video while we speak, just so I make sure everybody's understanding everything. I just don't want to have a video there with you guys watching it. So basically in this, just so that we recap here, is that what we're trying to do is free all these structures. We're trying to free the teeth and the mandible and the maxilla from all these different superimpositions by using tomography, by slicing, just taking one slice. So what it's going to teach you now is how we actually do that. So this is going to be an object right here. And what you're going to see is, I want you guys to imagine that this is the almost like a thickness of the body, right? So C, B, and A, each one is at one thickness of the body, right? So what it's trying to show you right now is that when you take an image,
these letters sit in different parts of the object, with the letter A positioned closest to the receptor and C farthest from it. The letter B lies between letters A and C. If the letter B is the object of interest and a conventional radiograph is taken to attempt to image it, shadows of letters A and C will be superimposed on the resultant image and obscure.
God, annoying. Do you guys understand that part? Can you guys just say something? Anybody? Does everybody understand that part?
Got it.
You guys can put like a thumbs up or a hands up, just if you got it. Other people got it? Okay. Sorry. All right. Oh my God, this annotation button.
Conventional radio.
So stupid. It won't allow me to.
Conventional.
Okay. All right. So everything was superimposed over each other, so we can't see anything in the middle, right? Now it's going to continue to say how we're going to do this.
And obscure the letter B. If a tomograph is taken to visualize letter B, the object would be positioned such that B sits in the focal plane, while the structures in front or behind it are blurred to the point that they do not contribute meaningful images. For illustrative purposes, the letters A and C will be moved above and below B. The selective blurring of the letters A and C is achieved by having the X-ray source and receptor move simultaneously in opposite directions to each other while the image is exposed. The pivot point of the movement of the X-ray source and receptor becomes the point of focus or focal plane. This is because objects at the pivot point remain projected onto the same point on the receptor, even as the receptor and X-ray source move, while images of objects in front or behind this point move across the receptor, and thus appear blurred. In this animation, it can be appreciated that the letter B is always projected on the same part of the receptor, while the images of letters A and C slide from one side to the other as the image acquisition progresses. This process of selective blurring results in an image in which the letter B appears sharp, but the letters A and C are smeared from one side to the other. In other words, because the letters A and C do not lie in the center of focus, they move relative to the receptor, as shown here by the red and blue shadows. The benefit of this effect is especially apparent when the letters are once again positioned so that they are superimposed on one another. Imaging all the structures of both jaws on a single radiograph provides a new challenge. This is due to the fact that the objects occupy a greater area than the single point described in the earlier example, and because these objects are on a curved plane. Rather than having a single pivot point defining a focal plane, the point of focus travels from one side of the jaws to the other. To simplify the concept and illustrate how panoramic tomography of the jaws is accomplished, the mandible and maxilla are shown as if they are flattened in a focal plane. The X-ray source and the X-ray receptor are also shown. During image acquisition, the source and the receptor move simultaneously in opposite directions, while at the same time, both translate across the jaws from one side to the other. Also note that the X-ray beam is limited to a slit so that only a small part of the receptor is exposed at any time. Since the objects of interest are actually on a curved plane, the plane of focus must wrap around the jaws. This curved focal plane is termed the focal trough. The structures placed within this trough will appear clear on the image. Now, when the panoramic radiograph is exposed, the receptor moves around the jaws while it is exposed from one end to the other. In addition to tomographic blurring, blurring of structures outside the focal trough is created by geometric magnification and due to varying speeds of rotation of these structures relative to the film. Patient positioning is critical in order to place the structures of interest in the focal trough. With proper patient positioning, the teeth and the jaws will be accurately represented, while incorrect positioning will lead to image distortion. Panoramic radiographs provide the dental professional with important information that is vital in the diagnosis and treatment planning for our patients.
So I hope you guys kind of were able to, it's the only way to understand tomography is to see it the way you guys have seen it right now. I can sit and talk here for 10 hours, but if you don't see it, it won't make sense. Bottom line is what we're trying to do with panoramic anatomy or with panoramic radiography is what we're trying to do is create a tomographic slice where the mandible and the maxilla, the area of interest, is within the focal trough. So what we're doing here is that we're blurring everything in front of it and everything behind it by keeping those structures outside of the center of rotation. When we move everything outside of the center of rotation, those things are going to blur because they are moving with the X-ray source and with the sensor, versus anything within the center of rotation, and the center of rotation is actually not moving because it's in the center of rotation, right? So if you imagine this moving, my finger in the center is nothing in the center is moving. What's moving is on the sides and in front of there. Does everybody kind of get that concept? It's the concept of panoramic imaging. It's important to just understand the basic physics behind it. Then we're going to talk about other things. But this idea that all the anatomic structures that we want have to be within the center of rotation for us to visually see it. If they are in front or behind it, they're going to be blurred. Does that make sense? If it makes sense, put me a thumbs up. If it doesn't, we can explain it again. Okay, I see some thumbs up. I'm hoping that others are also, okay, good. We can say, okay, perfect. All right, so basically, this is kind of in summary. The X-ray source and the film move simultaneously to blur the superimposing structures. So those structures that we saw before that was always superimposing over the mandible or the maxilla, we blur everything behind it and in front of it by doing that movement. So instead of a single point of rotation defining a focal plane, there's varying points of rotation that travel from one side of the jaw to the other. These varying points create a curve or a plane, which we are going to call a focal trough. So if you were to think about it, and we'll see a demonstration of that again. So wait, let me not blur this. So if you think about this one was a very simple rotation. It's just going one side to another. Now imagine this center of rotation is moving on an arch. So this is moving, but my center of rotation is also moving as I move through the arch. So we don't have a single point or a single plane like we saw with those beginning examples, just to have you understand the A, B, and C. But now we have a center of rotation. That center of rotation is going to move in a curve. That curve or movement of your center of rotation is called a focal spot, a focal trough. So what is a focal trough? It is the 3D or three-dimensional curved zone or image layer, we like to call it, where the structures lying in that zone are well defined on the panoramic image. Anything in front of it and anything behind it are all going to be blurred. So this is the most important thing. Why is it really important to understand this idea of focal trough? Because of two really important things. Number one, whenever we're positioning the patient, whenever we see errors on a panoramic radiograph, usually it is related to the patient not being put properly in the focal trough, right? So the whole point of having the patient stand in the machine, all the lines that we use, is to keep the mandible and the maxilla in that focal trough. If there's any errors in that, what we're going to see is an error in the panoramic radiograph. The other thing is to understand this idea of focal trough, and the movement of the center of rotation is going to be understanding your anatomic landmarks or your anatomic structures on a panoramic radiograph. Okay. So here's the basic concept again. Objects that are close to the film are going to be clearer. Objects that are further away from the film will be magnified. Remember in geometry, remember when we said, remember the idea where I said, if you have an object really close to the film, it'll be smaller. As we go backwards, they will become magnified, exactly like a shadow, right? So it's the same concept. Another important concept in panoramic imaging is the negative angulation of the beam. So in that, remember I told you we have a center of rotation. The center of rotation is moving around. Now imagine that, remember we always have a horizontal angulation, a vertical angulation, and a point of entry in every single type of image that we take, even in panoramic imaging. So the vertical angulation of a panoramic image is always in a negative degree. So your beam is always coming upwards in a panoramic image. So you have a negative angulation, of negative vertical angulation. What does this result in? Is that buccal objects will always project lower and lingual objects will always project higher. So let's take a look at how and why that's important. So this is just we're just looking at some images right now to understand. So if this, can you, by the way, I don't know if you can see my mouse. Can you guys see my mouse on my screen? Yes, okay, perfect. So if this was the X-ray source right here, and imagine on the other side of that, that is your film, okay? And I want you to look at these little dots, the black dots in the center. That is the center of rotation moving along an arch. That is exactly the line of movement. And that each and every dot represents the center of rotation. So this basically center of rotation is moving from here to here to here to here as it's going around the patient. So you can imagine it going kind of rotating as the whole machine is going around the patient's head. So this is your head right here. This is your X-ray tube. It's moving in this direction, and here's your sensor. And as it rotates in this direction, the center of rotation is also moving forward in an arch position, or in an arch direction, because of the arch nature of our image. So our modern panoramic machine shapes the image layer by moving the center of rotation and varying the relative respector speed through exposure. So let's take a look at how that looks like. See how that goes? It's going around, but the center of rotation keeps moving, so it's kind of going to go in and out. I hope that's kind of clear. Let's look at that one more time. So the movement, so the distance between your source and your receptor or your film is always constant. It doesn't change. Your center of rotation is going to move in an arch. So if we look at that just one more time, you can see that it's going downwards and then it goes back upwards as it moves around the patient's head. Okay, so the vertical orientation of a panoramic beam is in an upward direction, right? So if this was if we're going to take a look at this, I think I have it in a clearer image right here. Okay, so why is this important? Over here, we're looking at in A, we're looking at the tooth in a cross-sectional way. So on this side over here is lingual, and over here is buccal. Now on this side over here, you have the tooth, you're looking at the same tooth, but from the front. So one side is mesial and one side is distal, okay? Now, if you think about the inferior alveolar nerve canal, depending on where it is, buccally or lingually, in respect to the tooth, it is going to appear differently on a panoramic radiograph, giving us an incorrect appearance of the inferior alveolar nerve canal. That's kind of the clinical, let's say, the clinical importance of understanding the upward beam orientation. So let's take a look at this in detail. Now, here's your tooth in a cross-sectional, this is like that doesn't make sense. Anyway, it's a weird anatomy. So this is your buccal side of the tooth. This is the lingual side of the tooth. All right, so this is your bone. We've cut right through it. This is your inferior alveolar nerve canal. And this is what it looks like on a panoramic radiograph. Okay, so the distance between the roots of the tooth and the inferior alveolar nerve canal over here is going to be represented as the distance between the roots and the inferior alveolar nerve canal right here. Now, because of the upward angulation, we have to know that that's not very accurate. So let's see how that looks. Now, let's imagine that the inferior alveolar nerve canal was in a buccal location, not in the middle, but in a buccal location. Vertically, what it's gonna, this is where it's going to appear. Now, let's imagine that it was in the center. Let's see where it's gonna look. It is gonna look higher if it was in the center, right over here. Now, if it was in a lingual position, it's gonna appear even higher. So why is that important? As you can see in this panoramic image, it looks like the inferior alveolar nerve canal has 3 different distances from the tooth, when in reality, all I did was change the location of the inferior alveolar nerve canal buccally or lingually or in the center. But the distance between the root of the tooth and the canal itself didn't change. Do you see what I mean? So the distance between the inferior alveolar nerve canal and the inferior part of the tooth, or the periapical region of the tooth, hasn't changed. So this distance and this distance and this distance are equal. However, because of the upward angulation, what happens is, how is that seen on a panoramic image? It depends on whether they're buccal, lingual, or in the center. Is that clear? If it's not, please tell me you didn't get it. I see a few yeses. Just a few yeses. Does that mean no? That means it's not clear for others? If anybody doesn't understand it, can somebody tell me? No? Okay. All right. I will assume that you guys got it. Okay. All right. So in other words, inferior out in when we're looking at the distance of the vertical distance on a panoramic radiograph. So this is your panoramic radiograph. The vertical distance is this distance from the crest of the alveolar ridge down here. Vertical distance. That vertical distance, anything that is, it will be changed based on the location of that object, buccally or lingually, and not the vertical height. So we have to have that in mind whenever we're thinking about, whenever we're looking at vertical distances, we have to put in mind that they might be either buccal or lingual. So we can't take that into, because we can't take those distances to be completely accurate. So why is this important? Some people will look at a panoramic radiograph and decide to put let's say this would be an edentulous area, and decide to put an implant. If putting an implant in that area, they'll look at where the inferior alveolar nerve canal is, and they'll say, okay, I have about 10 millimeters. I'm just going to put an implant in here. What they might not realize is that distance might be inaccurate. It might be too short because the inferior alveolar nerve canal is located lingually and it appears too high, or it is buccally and appears too low, right? So here, that is sort of the clinical importance of understanding that. So again, they're all at the same level, yet they all appear at different levels on a panoramic radiograph. So anatomy, same height, different location buccolingually. The projection, it is projected at different heights on the panoramic radiograph, okay? So here's one vertical, whoops, oh man, this is gonna go on and on and on. Sorry. Okay, projected differently. Here we go. This is one height. This is the other height. This is the other height, even though it really is exactly the same. Okay, so panoramic imaging. So if we look at this panoramic radiograph together, I want you all to look at the panoramic radiograph. And what you can see here is you can see very clear images. You can see like the teeth look very clear. There are some bones that look very clear, but there also looks like there's other things going on. There appears to be like shadows and a few different things going on here. And if you're seeing what I'm seeing, which is the shadows and that, you're not wrong. And that's why when we look at a panoramic radiograph, we have three types of images. We have something called real images. We have something called double images. And we have something called ghost images. So because of the rotational nature of the X-ray source and receptor, the X-ray beam intercepts some anatomical structures twice during its rotation around the head. So depending on the location, the object may cast three different types of images. As I said, real images, or double images, or ghost images. So let's take a look at this. These are going to be the three types, and we'll talk about each one in detail. So who are your real images? The real images that you see, which are images that are clear and you're actually seeing them, are any object that lies between the center of rotation and the receptor. So the center of rotation and your film. And these are usually the images that are within the focal trough. They're usually sharp. You can see them very clearly. The further away they are from the focal trough, they will appear blurred. So here is your receptor. As you can see, this is your receptor. Here is your, each and every point here is a center of rotation in this specific location. This is the center of rotation, okay? So anything between this point and this is going to be a real image. So what we look and we find here, anything in this area is going to be a real image. So if we look at our panoramic radiograph, the real images here are obviously the mandible, the maxilla, the teeth, the maxillary sinus, parts of the cranial, the middle cranial fossa, parts of, there's everything you see here are considered, anything you can see really well and clearly is a real image. So what about double images? So if we go back in the panoramic radiograph, I think you guys are going to see it a little bit more clearly. You will have things that are imaged twice. So objects that lie posterior to the center of rotation and that are intercepted twice by the X-ray beam are considered to be double images. They are real images, but you see double of them. And they're usually mirror images of each other, and we will describe them as midline structures. So if we look at this here, these are objects. So this is your center of rotation. Each and every dot is a center of rotation, correct? So these are your center, this is your center of rotation. This is your center of rotation. Anything that lies between this, anything that lies behind this as in and is in the midline of the body, the patient, they will be intercepted twice because it's in the midline. As it goes around the patient's head, it's going to be intercepted twice. It's going to be very clear images, but they're going to almost look like mirror images of each other. So how is it going to look like? It's almost going to look like you've opened a book and you've opened that structure into two. So what are some midline images that we have, midline structures that we have here? Cervical spine. In a panoramic radiograph, you're going to see two of them. We only have one cervical spine, but what happens is it opens up into two and you see two of them. Another midline structure anterior to the spine. It's your hyoid bone. We have one hyoid bone, but what's going to happen to the hyoid bone? It's going to open up into two, and you're going to see two hyoid bones. They're not two, it's one, but they're double image of the hyoid bone. The other ones that we're also going to see, because remember, in panoramic radiographs, we see both hard tissues and we see soft tissues. So anything in the midline that's hard tissue or soft tissue, we're going to see. So things like airway, epiglottis, tongue, soft palate, All of those things are midline structures, and they all will open up looking like a book that's opened up into two. So let's take a look at these images here. Now I want you guys to look with me and see what you can see double of. So if we look at the side of the panoramic radiograph, if you look over here, we have one side of the cervical spine. If we look on the other side, we also have another cervical spine. Does the patient have two cervical spines? No. But because it's a midline structure, it is going to be intercepted twice. Down here, this is the hyoid bone. The hyoid bone, we have one hyoid bone. The hyoid bone will be opened into two. So what you're going to have here is 1 and 2. Are those two different bones? No, they're not. It is one hyoid bone open into two. The other thing that you will see is airway. So let's look at where airway is. And you're going to do all of this in panoramic anatomy in detail in another couple of days. But so you understand anatomy, you have to understand this concept of real image and double image. So look at this black space right behind the body of the mandible here. This black space over here is your oropharynx right here. So you have soft tissue behind, soft tissue in front, and in the center, you have a black space of air. That is your oropharynx. Now, if you look at the other side, you're going to see the same thing. You have soft tissue right here in the back, right in front of the spine, and then you have soft tissue here, and then you have a black space right in the center. Whoops. That is the airway. Do we have two airways? No, we don't. The airway is a midline structure. It will be opened up like a book on the side of your pan, and you're going to see two sides of it, even though you only have one. Okay? So that's another example. Those are the most important examples. You'll see with Dr. Akhdar next week other examples of double images that you will see on your panoramic radiographs. Okay? But just to make life easier, midline structures that are appeared in the pan, think about anatomy, any midline structure is going to have two double images. Okay. The second one is something we call ghost images. Now, ghost images are objects that are located behind the center of rotation between the X-ray source and the center of rotation. So it's the area behind here. So this is your center of rotation, right? This is your center of rotation, and your X-ray source is in the back here. So it's the region behind the center of rotation and the X-ray source. What happens in ghost images? So ghost images give us nothing. They are useless. They just decrease the quality of a panoramic radiograph, and we just don't like them, right? They are blurred and they're significantly magnified. So the main ones that we're going to see here, blurred images, are going to be ghost images, are going to be the posterior part of the mandible and anything located in that same level. So the posterior part of the mandible, the ramus, and let's say the ears and this area, that will all give us ghost images on the other side of the panoramic radiograph. They appear on the other side at the higher level. So if we're going to have a ghost image of the posterior part of the mandible, where there's this area right here, it is going to be projected on the other side, but higher and larger and blurred. So let's see how that looks like. I'm just going to I'm going to show a video of how that happens. So this is your panoramic radiograph right there being taken. The posterior part of the mandible is taken. Now it's going to keep going. And we're going to take a look at a patient wearing sort of an earring. It's going to be easier for you to understand it. So as it starts, it's going to take a picture of the earring as it goes through, and then the other earring is going to be identified, but it's going to be projected on the other side of the image. It is going to take a second, sorry. And what happens is you get it on both sides. And That is your earring right there. The ghost image of the earring, because they are intercepted twice. But this time it's intercepted from a much further position, okay? So what happens is, if this is the true image of the earring, this is your right earring. The patient has a butterfly earring and it's on the right side. The ghost image of this is projected up here, higher, blurred, and magnified. The same thing over here. This is the left earring, the real earring. It is also going to be projected upwards and blurred on the other side. And that's why we never have anyone put their earrings in while they are taking images. So an interesting thing to look at is to look at a panoramic radiograph of half a face. And let's see what happens when you do it on a cadaver. So this is all real images right here. These are all the real images you have. So remember, this is half a cadaver. This is the mandible, the maxilla, and this is the mandible. Now look at all of this over here, even though the patient only has half a face, right? Basically, what you're seeing is all the stuff we talked about before. So if we look at the soft tissue, here we have the tongue. This is the tongue. Because the tongue is the midline structure, it is going to be double imaged. So you get a double image. The dotted line is the ghost image of it. So you have double tongue. We have only one palate, which should be here. So this is the hard palate. This is the hard palate. What you see here is double image of the palate. This is double image of the soft palate. And what we see up here, all this white stuff, is the ghost image of the other side of the mandible, okay? So if we look at this, this is an even better example over here. So if we look at this, the patient is wearing hoops earrings here. So this is the right earring and this is the left earring. So what are these guys over here? They're not wearing double earrings. This side, when you what you see on the left here, this blurred magnified image, is the ghost image of the right earring. And what you see on the right side, the magnified and blurred image, is the ghost image of the left earring. So again, all of these posterior structures, whether that's the area of the ear or the area of the ramus of the mandible, they are going to be projected again on the other side, higher and more blurred. So let's take a look at some examples of these things on a regular panoramic radiograph. So we'll start out with our real images. You can see here all our real images is anything that you can see that's really, really clear. Mandible, maxilla, the teeth, maxillary sinus, all of those things are real images that are within our focal trough. Now let's look at double images. So double images, anything that is located behind the center of rotation and is considered a midline structure. So let's do this. 2 cervical spines. Do we have 2 cervical spines? No. So we see 2 of them because they are double images. Now the airway, once again, this black region right here. Here you have one and you have an identical one over here. What is that? Double image of the airway. The palate, the hard palate is right here. We have one palate, but it appears one and another one here. That's double image of the palate. Now let's take a look at the ghost image. So if we look at the left part of the mandible, I want you guys to look carefully at the left part of the mandible. If we go through the body of the mandible here, you can look at this density. Now, as I get to about the angle of the mandible here, you can see that the density of the bone here has increased. And you can almost see a line right there where that changes between this region and this region. This whole area, this radio-opaque area here that's giving me that increased density is basically the ghost shadow of the right mandible superimposed on the other side of the mandible. So what is this? The ghost image or the ghost shadow of the right part of the mandible. Now let's go to the right side of the mandible and see if we have the same effect. And yes, you can see it very clearly. Here's your normal density. And as we get to the angle of the mandible, again, you can see this line demarcating an area that's more radiopaque. Is it more radiopaque because it's diseased? No, it's not. It's just the ghost image of the other side of the mandible. And if you take if you look at my mouse here, you take a line, you can follow it all the way back here and all the way back to show you how you get that ghost image that goes to the other side and is slightly higher, larger, and magnified. Is that clear for everyone? Yes, yes, okay, great. Very good. So we're going to spend the next 10 minutes on image acquisition. And why is image acquisition going to be really important is because right after we do this, we're going to take a break and then we're going to do panoramic errors. Now, as you guys, I think you guys are expert right now on taking intraoral radiographs. You guys know that whenever we do an error or whenever we do a mistake in positioning within the patient's mouth, we get to see an error visually when we're looking at our images. For example, we have incorrect horizontal angulation when we're positioning our beam, for instance, or our X-ray tube. What is it going to look like on the patient, on the image? You're going to get horizontal overlap. Let's say an error that مثلا a lot of people were getting in the last few sessions. I don't put my film all the way back and I don't get the last molar. So my image acquisition, there's a mistake in image acquisition, which leads to an error in the image. Now with panoramic imaging, it's a little bit more complex than just the simple things that we do in intraorals. To understand that, and because you guys are not going to be doing it on your own, we have to look at how we take panoramic imaging in the first place. So I'm going to try, before I start this, I'm going to try to get rid of this like annotation and see if I can can I just do this on my own? Anyway, okay, I think I got rid of it. So let's watch this video carefully. I will stop in different points to explain things.
Panoramic radiographs are commonly used images in dental practice. They depict a large part of the maxillofacial region, including the entire maxilla, mandible, and dentition, on a single image. They allow visualization of regions that cannot be captured or are difficult to image on intraoral radiographs, such as the temporomandibular joints and third molar regions. Their larger coverage is also important in imaging pathology or trauma of the jaws and the surrounding tissues, since assessment of the entire abnormality is critical for interpretation and treatment planning. It should be kept in mind, however, that the principles of radiographic prescription dictate that panoramic radiographs should not be used as a means of surveying the jaws for quiescent pathoses. An additional advantage of this technique.
So this is just a reminder from our last lecture, and of course, Dr. Aqdar's lecture about prescription radiography. We don't use panoramic just for screening. We have to use them for specific reasons. That's just a disclaimer from the outcast, from the outs of it.
Is that it is more comfortable for patients since they do not need to open their mouth wide, nor have bulky instruments placed intraorally.
So one of the uses of panoramic radiographs is we will use them in patients that can't open their mouths. For instance, as you guys have seen with intraoral radiographs, patients should have the ability to open their mouth wide. They should have the ability to keep their film inside their mouth. They have to have minimal gag reflex, all those things. So if the patient can't do any of those things for any reason, then panoramic radiographs is a very good alternative to intraoral radiographs.
However, panoramic radiographs have a lower spatial resolution compared to intraoral radiographs. This makes visualization of fine detail and some dental diseases, such as caries and periodontal bone loss, difficult. For this reason, panoramic images should not be used as a substitute for intraoral radiography.
So just so that we all are on the same page again, with regards to resolution. So image resolution is one of the important factors that we think about when we're with the ALARA rule, remember, as low as reasonably achievable, what we want to do is we want to find the images with the lowest dose with the highest image resolution for that particular case, right? So what we're going to do with panoramic radiographs, we have to remember that panoramic imaging has low spatial resolution, which means I can't see details. So can I see caries, periapical pathoses, all these things? Can they be very clear? Yes, sometimes, and sometimes we won't be able to identify that. So intraorals are better. So we can't just substitute it to intraorals.
Of good quality panoramic radiographs is technique sensitive, and understanding the principles of panoramic tomography and proper patient positioning is critical in obtaining ideal images. Panoramic radiographs may be obtained using conventional film or digital sensors. The principles of patient preparation and positioning are the same for both of these modalities.
Just so you know, إحنا, and probably everywhere you go, nowadays, everyone uses sensor-based. Very rare anybody will use film. So ignore anything that has to do with film. You guys are using digital charge-coupled devices.
The first step in panoramic radiograph acquisition is the preparation of the film or sensor. If the radiograph is to be obtained using conventional film, a panoramic film cassette with intensifying screens is loaded with a panoramic film in the darkroom. Light exposure to the undeveloped film, pre- or post-image acquisition, will result in generalized film fogging or localized black regions. Forgetting to load the cassette will result in no film present to capture the image. Reusing an exposed film will result in the creation of a double image.
Anyway, this is not really important for you guys. It's kind of a little bit of history there, but what's coming is more important.
The cassette may contain markers that indicate the left or right side.
I feel like I don't want to waste your time. Okay, this is all film base, so let's just get to the sensor. Okay.
Panoramic machines. Rather than using a cassette with a film, the CCD sensor is a permanent component of the panoramic machine. The operator may still need to make sure the sensor is in the correct position for imaging. The next step is to ensure that the panoramic machine is turned on and that the rotating component of the machine, comprising the X-ray source and receptor, is returned to the start position. For digital panoramic radiography, the patient's information is entered into the appropriate database or software for image identification. Adjust the height of the machine to the approximate height of the patient, and then prepare the patient positioning device. Many manufacturers use a bite stick as a patient positioning device. This bite stick often has notches into which the patient will bite his or her maxillary and mandibular incisors. The patient is now prepared and positioned. Ensure that the patient removes all metal from the neck up, including dentures, earrings, necklaces, hair clips, eyeglasses, and facial piercings. Forgetting to remove metallic items may result in white or radiopaque shadows on the image. These opacities may obscure areas on the image, potentially compromising the evaluation of the structures in the region.
So very important, you guys. In intraoral radiographs, we said that everybody needs to take off metal and that kind of thing. However, in panoramic radiograph, it is very, very important to get rid of all metal within the head and neck, facial piercings, earrings, and everything. And because as you saw, even if the patient is wearing earrings and it's outside of the field of view or what you're interested in of the teeth, you will get ghost images all around the area of interest. So when patients come in and they say, I can't take off my earrings, I can't take off my piercings, you have two options. Yeah, you send them home and tell them, take them off professionally and then come back, or you don't take a panoramic at all and you take another image completely, intraoral image where the piercing or the earring is not within the field of view. But do not you'll see this a lot in clinics, whether it's in the Ministry of Health or whether it's in private practice. People will leave earrings on and I've seen so many things that have been very compromised just because of facial piercings.
The lead apron on the patient. Thyroid collars are never used in panoramic radiography since they would attenuate the X-ray beam and produce a white, non-exposed area on the radiograph. The following steps will position the patient so he or she is properly centered in the focal trough.
Before we get into the proper positioning into the focal trough, again, just as a reminder from one of our previous lectures, remember we said that the thyroid collar or the thyroid shield should never be used in panoramic radiographs. And that goes back to the concept that I told you before, that the beam is in an upward position. It has a positive vertical angulation, which means that even though the thyroid looks like it's far away from the field of view, because of this upward angle, what you're going to get is superimposition. Superimposition of the thyroid collar all over your panoramic radiograph. And I showed you an example of that where you'd have to redo the image. The same thing goes for necklaces. Why in the world would we get a necklace superimposed on the mandible? The reason is because now you understand the physics. You have a vertical angulation that goes upwards. So anything that's on the patient's neck will be projected upwards onto the area of interest. So no necklaces and absolutely no thyroid collar, which causes a huge lead artifact in the center of the center of the film. Whoops. No, stupid.
Panoramic radiography.
Okay, this is where we stop.
Properly centered in the focal trough. Guide the patient into the machine so that they are standing tall and directly in front of the bite stick. Have the patient bite into the notches on the bite stick, ensuring that his or her midline is centered on the stick and the mid-sagittal plane is straight. Some machines provide a vertical light line as a guide to accomplish this. If the patient is not biting in the correct position on the bite stick, then his or her jaw will not be aligned in the focal trough, and the image will be distorted. Failure to position the patient so that the mid-sagittal plane is straight may produce an image that is asymmetrical. If the patient is positioned such that the head is rotated to the left or right, the resulting image may be magnified on one side and minified on the other.
So here we're going to talk about our first error, true error other than having metal. If the mid-sagittal plane is not straight and the patient is moving one side or the other, basically what we're doing is essentially what we're doing is moving one side of the face closer to the film and another side further away. So that manifests visually as one side looking larger than the other. So you'll get an asymmetrical mandible or maxilla. So you always need to have the mid-sagittal plane in the center so that when the patient's biting down, it's right in the center. So you have equal sides of both mandible and maxilla, equal distances from the film. If you don't get that right, you're going to get one side is going to be magnified, the other side is going to be minified, and you're going to get asymmetry. The other thing that's really important in what they just said as well, do you see that bite stick that they asked the patient to bite on? If you realized the patient, what they do is they bite down edge to edge, meaning that they bring their mouth forward and they bite down edge to edge on that. Why is that important clinically? The importance of that clinically is when the patient is biting edge to edge, it means that they're bringing their mandible forward, which also means that the temporomandibular joint position cannot be evaluated on a panoramic radiograph. And the question usually is, why can't the position of the condyles be accurate on a panoramic radiograph? It is because of the edge-to-edge movement or the edge-to-edge cuspation that happens when the patient is taking panoramic imaging. Okay, I hope that's clear.
When the patient is fully or partially edentulous, positioning aids, such as cotton rolls and nose rests, will ensure that the patient is correctly positioned. Instruct the patient to grasp the handles of the machine. This provides stability for the patient and helps to keep him or her in the correct position during the exposure. Ensure that the patient is standing as tall as possible with his or her cervical spine fully extended. To accomplish this, place gentle upward and forward force on the back of the patient's head using your hands while the patient keeps his or her chin down and forehead forward. If the patient and machine are positioned so that the patient is hunched, the image produced will show pronounced superimposition of the cervical vertebrae over the midline region.
So this is our next error. Now remember, the cervical spine is a midline structure that you'll see on both sides, right? You'll see the cervical spine because it's double imaging. Now, what happens if the patient is slumped downwards and their neck, basically the cervical spine, moves from the backward position and is slumped into the focal trough? It's coming closer to the focal trough. What's going to happen there is you're going to get the cervical spine blurring the center of the panoramic radiograph. It's not completely within the focal trough. However, it's become closer than it should be. How do we avoid this? Is by asking the patient to stand as tall as possible. I usually ask the patient, put my hand in the small area of the patient's back, and it makes them يفردوا ظهرهم على الآخر, which makes the spine come out of the area of the focal trough and basically stays further away. If they slump inwards, it's just going to go right into your focal trough, and you're going to see too much of the spine superimposed in the center of the panoramic image.
Making evaluation of structures in the area more difficult or impossible. Also, if the patient is hunched, the lead apron may become positioned within the path of the X-ray beam. This is exacerbated because the beam is directed in an upward direction from below the patient's neck. The resultant attenuation of the X-ray beam produces a white triangular artifact or shark fin-like structure projecting from the bottom of the film.
So basically what's happening, your patient is hunched forward, their neck is in front, and when they hunch, the shoulders are higher up. Now, if they're wearing that lead apron right there, now you're bringing the apron بدل ما كان هنا تحت, now you're bringing it up here because they're slumped. And now that beam that we said we don't want to come in the thyroid collar, now even من غير thyroid collar, it's coming through the shielding that you have on their shoulders, and you're going to get a typical shark fin appearance because of that upward positioning, okay?
The height of the machine can now be adjusted more precisely so that the patient's chin is on the chin rest and the patient's allotragus line is approximately horizontal. A horizontal guide light may be present to assist in this positioning. An alternate guide to determine how far a patient's head should be tipped up or down is to look at the maxillary and mandibular incisors from the side of the patient and to position them so that both the upper and lower teeth are positioned as vertical as is possible at the same time. This positions the alveolar bone of the anterior region within the focal trough and therefore produces a clear image of this area. If the patient's chin is tipped too far up, the occlusal plane appears to be frowning or flattened, and there is superimposition of the palate over the apices of the maxillary teeth.
So this is going to be the next error. Now, after we had the patient stand up really straight, after we had the patient, the mid-sagittal plane was exactly where it is. Now we have to make sure that the height of the patient is correct. We don't want them going up and we don't want them going down, the chin. So if the chin is upwards, what we're going to get is an occlusal. If you think about yourself while you're looking upwards, what you're going to get is an occlusal line, or the occlusal line between the maxilla and the mandible that looks like a frown, or it's going to be very flat. So as you can see here, you can see that this is a frowning panoramic radiograph, meaning that the patient is too far up. When you put the patient too far up, what you're also doing is you're bringing the palate downwards, and the palate, when you bring it downwards, it is going to superimpose over the teeth. So what we want the patient to be is always tipping their chin at the right position, where the teeth are completely behind it is only air. We don't want to see the palate. We don't want to see anything else. Okay, so let's take a look what happens with the opposite side.
With the chin too far down, there is an exaggerated upward curve or smile of the occlusal plane, and the mandibular incisor region may not be seen clearly because it is out of the focal trough. Structures, such as the condyles or mental region, may also be cut off the image.
So what's happening here is the opposite. So the patient, instead of being positioned with their chin right in the middle, we position them downwards. So what happens? You get an exaggerated smile line instead. The very tip of the mental area is cut off, and now your condyles are rotated upwards, and that is cut off. So if they're too far up, you're going to get a frown line or a flat line. If they're too far down, you're going to get an exaggerated smile.
While looking at the patient from the side, have the patient smile so that the maxillary canine can be seen. The anterior-posterior position of the patient is now adjusted so that the canine light line passes approximately through the maxillary canine in a vertical direction. If the patient is positioned too far forward, there may be minification of the anterior teeth, and with the patient too far back, magnification may occur.
So what is happening here is now we put the patient, remember, we put the patient mid-sagittal plane, okay? We had them extend their neck as much as possible. Now we put their head in the machine, and we put their chin in the perfect location. But now we need to make sure how far forward and how far backward they have to be within the machine. Now the forward and backward of the machine is going to be identified by the canine line. We have two lines in the machine. When we ask the patient to smile really big, there's going to be a line. We want those lines to go right through the canine. If the patient is too far forward, those canine the line that's going in is not going to be on the canine. They're too far forward, so it's going to be back there. So what's going to happen is you're bringing the patient's anterior teeth too close to the film because they're too far forward. So what happens? Remember what we said about the shadows. When we bring it too far forward, you're going to get minification of the teeth in front. Now, the opposite, what happens if they're too far back? Again, your canine line is there. Now, let's say they're too far back. Now, the canine lines, or those lines الثابتة هذه, is going to look like they're too anterior. So they're back here. What happens is that you're moving the whole mandible and maxilla further away from the film. So what you're going to get is magnification of that area.
Ensure that the patient's shoulders are not in the path of the machine and make any necessary adjustments to create room. If the machine hits the patient's shoulders, then it may cause the patient to move, or it may stop the machine, terminating the image acquisition prematurely and resulting in a partial panoramic image. Next, close the temple supports on the patient's head to reinforce its stability. Describe to the patient what will happen during image acquisition, including that the film and X-ray source combination will rotate around his or her head, the length of time of the exposure, and any sounds that will be heard. This will help ensure that the patient maintains the correct position and stays still during the exposure. Instruct the patient to place his or her tongue flat onto their hard palate and to close their lips around the bite stick. Ask the patient to hold still, maintaining the position until instructed otherwise by the operator. If the tongue is not placed on the palate, there will be an airspace between the dorsal surface of the tongue and the roof of the mouth. This creates an overexposed black or burnt out region, which obscures clear visualization of the apices of the maxillary teeth.
So one of the most important things that we're going to do here, again, this is going to be all about anatomy when you guys do anatomy. So when the patient, after you put the patient correctly in the machine and everything's great, you're going to ask the patient to swallow and stick their tongue at the roof of their mouth to close out the airway. Because if we don't close out the airway, you're going to get this area of air. And as you can see, because all of these things are kind of like shadows, you then now obscure the apices of all of these teeth. The other thing is we're going to make them close their lips around the area that, around the bite stick, because there could be another error that could occur.
If the lips are not closed, an overexposed black region corresponding to the open oral orifice.
So if we look at this, if the patient has their mouth kind of open, this open orifice here, again, it's subtle, but you can see it over here as a black shadow. That is going to superimpose over the anterior teeth. And again, you won't be able to see. These are burnout areas, almost like burnout areas. The oral cavity and the open mouth or the open orifice. Oh.
Panoramic crowns of the maxillary and mandibular anterior teeth. Movement of the patient during the exposure will produce a blurred image.
Now, movement is an interesting one in panoramic radiographs because it goes around the patient's head for some time. It depends on when the movement happens. So you might get a movement artifact that involves all of the pan. So somebody's like coughing or whatever. And it might be a time where the patient just swallows. During that swallowing time, you'll see an area on the pan that looks like there's movement and the rest of the pan looks normal, like you can see in this picture right here.
The machine is now prepared to expose the film or sensor. Select the exposure parameters, including the patient size and the peak kilovoltage and milliamperage settings. Incorrectly selecting the exposure parameters may result in images that are over or underexposed. The operator must be behind a barrier.
So in this part, and it's going to be really important for our patients, is that we are going to change the kilovoltage, the MA, and the time depending on the patient. So for children, we're going to child size our dose, correct? For kids, they need much lower doses to produce a proper image. And for adults, we have adult patients. And in adults, I think we have two different settings, one for larger adults and one for smaller adults.
Exit the room to activate the exposure button. An audible beep will be heard while X-rays are being emitted. Some machines require the operator to hold the exposure button for the entire duration of the exposure. When the exposure is complete and the beep is no longer heard, re-enter the operatory and remove the patient and cassette from the panoramic X-ray unit. Some machines require a button to be pushed in order to return the film and X-ray source combination to its start position. The film or sensor has now been exposed and is ready for processing. Once the film has been developed, it is reviewed to ensure that it provides a quality image. Occasionally, errors in panoramic technique produce an image that is suboptimal in quality and may require a retake of the image with appropriate adjustments. A radiographic interpretation is completed at a later time. Dental radiographs provide the clinician with important information.
Okay, that's done for this video. Before we take a break and come back to do errors, so for errors, we're going to do more of an interactive session together. فخليكم معايا على الخط بس it's going to be a bit more interactive. Does anybody have any questions about panoramic physics and positioning? Anybody? Before we move on after. Yeah? Everyone's okay? So we're going to take a 10-minute break. Actually, you know what? Let's make that just 5 minutes. Let's take a 5-minute break so I can just put everything on and get everything ready. And then we'll come back. Please do come back. Ashan, again, this is going to be really important for your next session. And panoramic errors, panoramic anatomy is a very big part of your examination. I want you guys to really understand it if you have any questions to ask them. Okay, so I guess I'll see you guys in 5 minutes. Okay.